All right. Hello. This is Jacob.
Hi.
Hey.
Hey.
This is Jacob Avila of the Ultrasound podcast, and over here we have Mike Mallon. Ladies and gentlemen.
I'm Mike. Do I have anything in my teeth, Jacob?
Yes, it's disgusting. I'm just kidding. You're fine.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Mike, why do we sound all echoey? What's going on?
It's the holidays, baby, and that means there's family in town. And I am recording in my garage, which is actually pretty sweet because if I get too bored with this topic that you're going to tell me about today, I'm just going to go do some squats.
Yeah, I'm recording in essentially like a mudroom closet that I put a desk in for this podcast. So
nice.
That's why it's pretty echoey.
But I can hear you 3 times. Each time you say something, I hear it 3 times, which makes it 3 times as good.
That's right, 3 times as important. Now,
Right.
The reason why we're doing this, even though it's the holidays, we have family around us, because we were going to talk about a very important topic. We're going to talk about the freeway of the blood, if you would, which is the aorta. So right here, we see the aorta. Like I said, I call it the main freeway. And what we're going to talk about today is we're going to focus on the abdominal aorta. It usually starts off right underneath the diaphragm, usually around T12, goes all the way down until it splits into the iliac, which is around like L4. So you have like just this finite area that you're evaluating on ultrasound. Now, the majority of these aneurysms are going to actually happen infrarenally, which is below right here, which is actually a good thing because I think that's like the easiest part of the aorta to actually evaluate. Like suprarenal, sometimes you have a hard time because there's all this like bowel gas. There's like the duodenum. There's the
You think
stomach.
so?
Yeah,
Sometimes
I think
feel
it's
like
harder.
Sometimes I feel like going through the liver there, that suprarenal stuff's a little bit easier to see. But
Really? No, fair enough.
Yeah. What do I know? I don't know.
In any case, below the kidneys is where most of them happen, but they can happen above the kidneys. Now let's talk about sizes, because we have to know what a baseline is. Now, normal is going to be between 1.8 and 2 centimeters, and abnormal, or AB normal, is going to be 3 centimeters. You got to take that with a grain of salt, though. Like, these numbers are for adults, and specifically for adults that are older than the age of 50. So if you have a younger patient, if you have like a kid,
So if I'm trying to diagnose like a pediatric AAA.
which can happen if they have connective tissue disorders, right? They have like some
all right.
Marfans or something
Fair
like that. It
enough.
can happen. I'm just saying it can
Fair
happen.
enough. Okay. So I would have to do like a body weight adjusted size for the diameter of the AAA or something.
I think there's like an MD calc
It's
for it.
one. I think it's 1 millimeter per kilogram.
Yeah, so the number is, it has to be greater than 50% of the normal diameter, whatever normal happens to be. So in case you have somebody below the age of 50 that you're trying to evaluate, that is another way to know if it's AB normal or not. By the way, Mike, why did I just say AB normal? Is there an AD normal? Is there ad normal? Why did I say
I'm not
that?
aware of an abnormal, but
I'm not going to say that again. I'm sorry.
If there was abnormal, would it be normal or not normal?
I think ad normal must mean
would
normal.
it be? I think it would be twice normal.
It would be twice normal. All right, I like it. Now, really abnormal is greater than 5 centimeters. Now, Michael, like, why do we care? Like, I mean, if 3 centimeters is a little bit abnormal, 5 centimeters is like a little more abnormal. Like, why does it matter after those 5 centimeters? Like, who cares, right? It's just like linear, right? Isn't it linear?
I think you're trying to hit me up on some physics stuff that I don't remember from undergrad. Is that what you're doing?
Yeah, look at this guy right here. Look at how smug he looks. This is Laplace. I'm probably saying it wrong. Laplace. He made this law. He made it up. That basically it states that as the vessel diameter gets bigger and the wall gets thinner, which happens as things balloon out, the stress on the wall is actually going to increase. So it's not like a linear increase in the risk. There's not a linear increase in the size after 5 centimeters. It's actually exponential. So after 5, you have a super high risk of it rupturing and getting bigger, and then potentially even rupturing earlier if they're above that 5 centimeters. So basically, if they're below if they're 3 centimeters to 5 centimeters, you can surveil it. Is that right? Surveil it.
Hey, you said he made it up. I'm not sure that's fair. I don't think he made it up. I think he might have used the scientific theory to come up with that. But whatever. Yeah, he made it up. He just came
Listen,
up with it one day.
Science is all heebie-jeebies, mumbo jumbo, anyways, right? I mean, this
I'm
is
not
all,
sure I'm
no?
not sure that we're
No?
allowed to use the word scientific theory right now. Anyway, I think that might have been one of the outlawed words.
Okay. Oh, that's right. That's right. One of the CDC outline. Yeah, that's right. That's right. All right, we'll have to. We'll
I'll try not
we'll
to say that
edit it.
again. Sorry about that.
It's
So
okay.
basically, the bigger the vessel gets, the more the pressure sort of on the wall, and the thinner the wall, so it's more likely to rupture. So big vessel equals
Got it.
bad.
That's it. Big vessel equals bad exponentially. Now, we got some risk factors briefly. Now, the risk factors are going to be the ones that you think about. Hypertension, lipids, remember those connective tissue diseases, those ones, atherosclerosis. Age, actually, there's some good numbers for age. So above the age of 65, you have an odds ratio of like 5.4. And this is if you suspect a AAA. Greater than 75 years old, 75, 79, you have an odds ratio of 14.5. Isn't that crazy?
Lord, that's high.
14.5. You're a man. It's kind of sexist,
I'm a man.
but it's stats.
I'm a man.
Odds ratio 5.7. What's interesting, though, is that although men are more likely to have a AAA, women are 4 times more likely to have it rupture. Isn't that weird? A big one here is actually going to be smoking. So smoking, it's the reason I'm making a big emphasis here because it's like a modifiable risk factor. So if you have a 35 pack year history, which most of my patients I feel like have like 70 pack year histories. If you have a 35 pack year history, odds ratio 12.1.
That's insane. The only thing worse is being old.
That's right. That's right. And then you know how we like actually, so more than 90% of patients with AAA have smoked cigarettes at some point in their life. And AAA is second only to lung cancer and its epidemiology and its like association with cigarette smoking. So like
that's crazy.
It's more important smoking is a more important risk factor than like for AAA than strokes and heart attacks. So we don't even think about smoking being like that important for AAAs, but it totally is.
Well,
Now-
there was that like whole recommendation that came out by somebody that basically like any male over 65 who has a history of smoking is supposed to get a abdominal ultrasound, right? I mean, there's a reason for that because the odds ratio is 12.1. I mean, that's crazy.
Right. And it increases like every year that you have it, it increases exponentially. So it's I agree, it's a big deal. And they, by the way, those surveillance things actually catch a fair bit of AAAs. Like they really do. It's like I think it's like 5% of everybody screened will get it, which I think is kind of important.
That's impressive. Yeah.
Yeah.
That's a high number. Like, I mean, you think about like the screening tests that, we typically think about like colon cancer and stuff. Man, that's crazy.
Yeah. So Mike, walk me through presentation. Like what have you seen your patients with AAA present as before?
I mean, they normally, with the AAA, they either come in with no complaints whatsoever, and we happen to find a AAA in their abdomen.
Yeah, right.
Or they come in with a ruptured AAA, and then they've got pain, mostly in their back, hypotensive, maybe a distended abdomen, big pulsatile mass. It's not usually, it's not often there's not a lot of question in the diagnosis, I guess, is what I'm trying to get at.
Yeah, no, I agree with you 100%. That's actually literature-based as well. I mean, a fair bit of these are just found on accident. Like even 5-centimeter ones are found on accident. But sometimes it's a little bit of vague belly pain, a little bit of vague flank pain. And when they rupture, that's when they're in shock or whatever. But yeah, just like you said, it's variable. Now, one thing that I like to do is I like to always make sure, like, do we need to do this, right? Like, what does the physical exam show for this? I actually looked it up. There's this study, this JAMA. Have you seen these, Mike? The Rational Clinical Examination that JAMA.
Yeah, I like these things. These are pretty awesome, actually. I try to read all of them. Yeah.
Yeah. No, they're good. And they talked about like the palpation sensitivity. And if you have a 3 to 3.9, look at these numbers: 29% sensitive. If it's under 4 centimeters, you're 50% sensitive. It's less than 5, and if it's greater than 5 centimeters, you're only 76% sensitive.
I want to know what the sensitivity is for like a 12-centimeter aneurysm.
It's probably pretty high.
I think it's 100%.
It's probably 100%. You will not miss those. Yeah, and the specificity, I think the specificity is pretty good, but in the ER, we care about sensitivity. One thing I will mention, because I mean, the physical exam is not some, the ultrasound is not there to like replace it. It's there to like for you to use it as part of your toolbox. And one of the things that they do say is that there's been no incidents of people causing a rupture with doing the physical exam.
It's good to know.
Yeah,
What about for
that was
ultrasound?
That the ultrasound. Well, if you have to palpate to like get there, you have to like put your hands like in their belly, and I imagine that is much more likely to rupture than your.
I don't know. I can push pretty hard with that ultrasound probe, which I'm sure we'll get to later.
Yeah. Right. All right. So let's talk about what it looks like. So this is my super high definition cartoon. Do you like this? It took me like 3
I
hours.
actually really
to make.
like this one. No, I think it's super slick, man. I'm impressed.
3 hours.
I like how you even made the aorta white. You were like, I don't even care if it's red. It doesn't matter to me.
Yeah, it was too much work. I couldn't do it.
Yeah.
So this is basically a graphical representation. On this, the probe marker's over to the right. So this over here is the IVC on the patient's right. The aorta's on the left side. And then this is your vertebral body shadow. And here is the ultrasonographic representation of what we're seeing. The first kind of branch point that I like to look for is this guy right here. See this little like branch point right here, Mike?
Oh, yeah. I got you.
Yeah. That's a little celiac action right there. I don't really remember what all the branches are. It doesn't really matter. But this is the celiac trunk with, I don't know, one's like the hepatic artery, right?
Splenic artery and hepatic artery. So the splenic, you can actually see the splenic coming off.
Is that the one off the left here?
On the right side of the screen, right?
Left of the patient, though.
Yeah, left on the patient. Yeah, right side of the screen, left on patient is
Okay,
the
I see it
splenic
right here.
artery. And then you can see your hepatic coming off too.
Wasn't there a third one?
Yeah, well, there's the SMA.
No, there's a third branch off the celiac. I think it's like
Oh, there's like the
gastroduodenal.
gastroduodenal.
Yes.
Yeah, but I don't think that comes off the celiac. I think that comes off the hepatic.
Okay, fair enough.
I could
Well,
be totally wrong about that. That's been a long time.
Somebody help us. All right. All right. So the next kind of branch point you'll see right here is going to be, keep going down, a little more of the celiac right there. Boom. This right here, that is going to be your SMA. People call that the mantle clock sign. It kind of looks like a mantle clock. I don't think we have those
Because
anymore.
everybody has mantle clocks.
Everybody's got a mantle clock.
I've got 3 on my mantle.
Yeah, I have none.
Actually, I've purchased extra mantles for my mantle clocks.
I like it. So that's the SMA. The IMA is a little difficult to see. But basically, you want to follow it all the way down until you get to the split of the iliacs, which is, wait for it.
I've actually come to terms with the fact that the IMA doesnn't exist. Like I don't
not
even
real.
believe in that artery anymore because I've never actually seen it on ultrasound. Like,
It's not real.
How is it possible?
Split.
It doesn't make any
There's a
sense.
split right there.
Hey, all right.
Split. It took forever. But yeah, no, I agree with you. I think that is a conspiracy, the IMA. I don't think it exists in real life. All right, let's go through what it looks like. So this is an examination. So you want to start high up in the epigastrium, as high up as you can, right? Because you want to get it right as it pops off underneath the diaphragm. And I'm going to pause it right here, right about 6 seconds or so. And I want you to see right there. You see all that shadow that got in the way, Mike?
Yep. Oh,
do you
yeah.
have some tips to like fix that? Like when you get, because that's a big issue, right? When you get like your bowel gas kind of be in the way.
Yeah, I got a couple tips. One, you can push harder, right?
Okay.
2, you can just kind of sit there for a little while. It would just like slow constant pressure, and that'll help sort of move that gas out of the way. Mm-hmm. You can also use your other hand, the hand that's not holding the ultrasound probe, to help you push down, so you can get a little bit increased pressure. Or you can just you can also like slide up to where that gas isn't, and then angle your transducer into the location of the type of part or the area of the aorta that you want to see, right? So because typically that's just transverse colon coming right across the middle of the abdomen there. So you just got to hit it from a slightly different area in order to get through it.
Yeah, I didn't think about that fanning thing. That was a good point. So as you can see, like here, you can see that the bowel gas kind of gets in the way, and then most of the time I'm just pushing a little bit, just like you said, maybe just holding pressure, and eventually like the bowel just kind of peristalsis out of the way as you hold gentle pressure in the area. And then I'll fast forward it here, and you want to kind of just go all the way down, fixing your depth until you get to the split of the iliacs, which is usually right around the belly button. So there's here's just coming down. There's that split right there. Now, Mike, I think there's 3 ways to like fix the issue with the belly button, right? Because the belly button's usually full of air. What are your what's your favorite way to get around that issue when the belly button kind of gets full of air and you can't get through it?
I just fill it up with gel.
That was like that's like the weirdest way to do it, but it is definitely a way you can do it.
Just a big mound of gel in.
Just stick it, put it right.
I usually stop right above the belly button and I fan down.
Nice.
So right before the belly button, then I fan down to the iliacs. And then So Jacob, how big can the iliacs be? If the aorta can be 3 millimeters or 3 centimeters, what about the iliacs?
So the iliacs, since I always think about it like it's like you're dividing the aorta in 2. So if the abnormal size for the aorta is 3 centimeters, that would mean that the iliacs, it's like 1.5 centimeters. So you can get that's like your number. And I've one time so far in my career, so it happens, seen an isolated iliac artery aneurysm that wasn't in the aorta. Have you seen any of those? Have you seen any of those?
I had one. I had a guy die on me in the ICU with one.
Oh my gosh, that's crazy.
Yeah, he ruptured an iliac artery aneurysm and died. Yeah, bad news.
Yeah, man, and that would be like hard to like identify too, if like because it's so like kind of rare, or whatever. But I guess it should be on our differential. I think like the iliacs are kind of like a thorough versus like a 2-point like DVT examination. You know, like
Yeah, I
you
hear
probably
ya.
shouldn't be doing a 2-point. Like when I'm doing the aorta, I actually will usually follow down the iliacs like a few centimeters down after the split just to like see. I mean, do you usually do that? Or you usually like stop right at the? I mean, I don't want to
I
do extra
usually
work.
stop right at the iliacs, to be honest. But I mean, I commend you for going a few centimeters down on the iliacs. That extra 3 seconds that you're willing to take that I'm not is probably worthwhile.
All right. So this is the typical way that we do it, just like anterior abdomen. But there is a different approach that you can take. What different like windows can we use, Mike?
For the aorta?
Yeah. Like if let's say like for whatever reason, let's say they got a big like huge laparotomy incision anteriorly, and you can't get to the aorta. I mean, are you just like SOL,
You can
or is there
do
something
a
else you can do?
you can do a TEE.
Okay, agreed. You can't do a T. How would you get it down that far? Like that's intense.
Well, you just get into the stomach and then you look through from the stomach.
Really? Okay, I've never done that.
Yeah,
I need to, like, study up on
the
TE.
transthoracic aorta is great with TE, right? I mean, it's all transesophageal, so you're
Yeah,
looking
that's true.
right, you're looking right at the aorta. But I don't know, transrectal maybe? Is that what you're asking?
Yeah, I usually use the linear probe for that. Actually, it works pretty well. No, another thing you can do, it's a little difficult to do sometimes, but you can actually go through the liver. You can do a transhepatic view or right upper quadrant view.
Yeah, I've done that for the IVC some. I haven't done it much for the aorta. Does that work pretty well for the aorta?
Medium. I mean, it's an option. The best view it would be to do it anteriorly, but know that if you're struggling, you really need to get a view of that aorta at the bedside. You can go through the liver, as you see here in these two images. On this one on the left, we actually see both the IVC and the aorta in the view here. Here's the IVC, here's the aorta.
Nice.
Then over here, we got a big pleural effusion that's actually getting us a little more of the, over here you have a little more of the thoracic aorta actually above the diaphragm. So it's an option. It's maybe not the best view, but it's definitely an option.
Jacob, I got to say that there's not many things about the ultrasound of the aorta that's considered a hot topic, right? Like there's not many things that are well contested. But one thing that I have heard a good bit about, and it's interesting because I hear different things from ER docs and from ultrasound techs, is what plane should we be ultrasounding the aorta in? Should it be in a long axis or in a short axis? And if I ask the ER docs, and I've been learning my whole career that we should do it in a short axis, but then you ask the ultrasound techs, they think long axis. So what's your take, since you're an aortic master?
Well, I don't know. Like all this is just kind of like anecdote. I think that if you want to do a thorough examination, you probably should do both. But here's my problem with, and this is specifically for aneurysm, not dissection. Now, here's my problem with it. Now, let's take this right here, a little cross-sectional view at a super high-res image I made through Keynote. So here's the aorta. You want to make sure that you get that beam right through the middle at the widest point to get a good measurement of that aorta. If you're in short axis, it's very easy to know where the widest point is, right? If you're in long axis, you might be getting it here at this area, or you might be a little off center and be getting it a little closer to the wall, which would give you an artificially smaller number to that aorta. That's my only issue with it.
Okay.
What
That's
do
what
you
you're
think?
saying. I teach both. I mean, I teach, look at it in both long and short axis. And I guess my feeling is that way you're not going to miss anything, right? So
Yeah, that's fair.
That's fair. If there's I guess the only thing that might be hard to catch on a short axis is like saccular aneurysm. I feel like you could
man, that's a good point. Yeah.
It might be harder to pick up.
Yeah.
But I mean, theoretically, you'd still see it. I mean, you should still see it on both views, right? I mean, and as long as you make sure you're in the center of the aorta for the long axis, you should be getting a good measurement too. But if you just do both, then you don't even have to worry about it, right?
Yeah, that's true.
Plus, I think you got to do the long axis looking for dissection, which, I don't think we're really going to talk about on this podcast, but I mean, you always got to put color Doppler on these things and make sure there's not a dissection flap.
Yeah, agreed. And I do think like dissection, it's definitely a lot easier to see them in the long axis and easier to not miss, definitely. Yeah, sweet. All right, so aorta. This is a regular aorta. This is an aneurysm. So it's just a big aorta, right? I mean, it's not that complicated. It's just a big aorta.
This is a large white circle.
It is. Now, this is sometimes what it looks like. Now, Mike, do I want to measure this guy right here? This little lumen. Is this the right measurement?
Jacob, you want to measure from the outside to the outside, brother.
Oh my
You don't want
gosh.
to measure the inside. Come on.
I keep forgetting.
on.
Rookie mistake. So this
mistake.
stuff, you can't forget this stuff right here. And this is something that happens. You know, like this is the part that's got the flow in it and everything. Fuck, my GoPro just died. I think it'll be fine. This is a part that's blood flowing, but all this is clot. So the aneurysm is all this. Like if you just measure this area right here, then you're going to falsely think that it's normal when in fact it's just like this massive thing, you know? So make sure that you measure that whole thing. Here's another example here. And I'm going to pause it right there. Right here. And you can see that the bowel gas like super gets in the way of this aorta right about there. All you do is a little extra pressure and then you can see it. What do you think of this guy right here?
Oh man, wait, what's going on there? So like there's all that hyperechoic stuff in the center and then there's like a pulsating single lumen. I don't know, dude. That is
really weird.
freaking weird. That is, you know what that is? That's, what do you call it? It's, what's the snowstorm appearance on the,
It's a molar pregnancy.
that is a molar pregnancy. That's
You're right.
exactly what we're looking
You're
at.
right.
It's a pulsating molar pregnancy.
I
Yep.
put this in the wrong lecture trailer. Right? Actually, what this is this is like one of the biggest AAAs I've ever seen. So here's like the vertebral body down here. This whole thing is a giant AAA. This is a previous stent. And you know, I'm near the iliacs because you can see like the split start right there. And you can see it. There's actually a pulsatile blood flow on the outside. This is an endo leak, which actually is fairly common. I think there's something like a 1% risk per year after a AAA repair of an endo leak. It can cause similar symptoms. Yeah, so just a way it can present. Okay. So we talked about like that saccular aneurysms might be difficult to see on ultrasound. Here is a saccular aneurysm on ultrasound. This looks kind of weird. And here it is in long axis. You can see here this little like outpouching here. This is a small percentage of aneurysms, but they are a way that they can present and they can still rupture and all that stuff. So they're not always going to be like just a whole aorta dilated. You might have this like focal little area. All right. So we talked about it, right? AAA, AAA, 1, 2, 3. If it's greater than 3 centimeters, it's abnormal. And we talked about if it's greater than 5 centimeters, way abnormal.
So here's one thing that bugs me, Jacob. Like, I get sick of measuring these things when they're obviously normal. Like, do I really need to measure these things, you know? Or can I just say, like, it looks normal, I'll keep going? Or even when they're big, like, is there a quick way to get around this?
Yeah, so, I mean, you should measure all of them. But if you're in a pinch, you know, you're in a really busy ER, a good kind of rule of thumb that I've kind of came across is that the average, and this is in an adult male, the average vertebral width, so that's, you know, left to right width of the vertebral bodies at L1 to L5 is around 4 to 5 centimeters. So for me, and there's my references right there, for me, if I think that the aorta is over half the size of the width of the vertebral bodies, then I will measure. If it's less than half of the width, the likelihood of them being 3 or less is a little bit higher. The right answer is always measure, and always measure in 3 places, like so superior, a middle, and right before the iliacs. But in a pinch, this is something that might guide you to when you need to actually, you know, measure it or not.
Nice. I like that.
So let's talk about our accuracies of it. Look at this. This is a meta-analysis, academic emergency medicine. It's an important journal article. And they did all this studies. They included a few studies. And they found that we bedside emergency physicians have a sensitivity of 99% and a specificity of 98%. I mean, what do you think about these numbers? I mean, they're just like phenomenal numbers. And the reason why they're so good, I mean, look at this. So I got a CAT scan here, and then right next to I'm going to put the ultrasound. Look at how identical this looks. Wait for it. Boom, right there. I mean, obviously, like we can definitively always rule in and rule out this AAA. What?
I don't know, buddy. I mean, like, I have trouble believing that. Like, I consider myself a pretty decent ultrasonographer. Like, you know, I'm well within like the bell curve, right? And I don't have a sensitivity or a specificity of 99 and 98%. There's no way. I mean, I would say that at least like 20% of the time, I can't even see the aorta because of bowel gas. So how am I going to have such a good sensitivity and specificity? It doesn't make any sense.
Yeah, I mean, you do have a good point. Let's look at all these studies here. These are all the ones, these are PubMed IDs they talk about in these meta-analyses. And they actually, like, kind of sort of mentioned, like, they don't make a big, like, deal of it, but in all of them, there's a small amount, but significant amount that they actually excluded from their meta-analysis because they could not see it. And there's also, like, a couple of them talk about, actually, that there was possibly a selection bias, right? Which I think is, like, it's Great point. I mean, I 100% agree with you. I think it's sensitive and specific if you can see it. Like this article right here sums it up perfectly. I'm gonna read it to you. Our results can only be applied to situations in which emergency physicians are able to confidently identify the abdominal aorta by ultrasound. More studies required to determine what percentage of all attempted ED ultrasound measurements of the abdominal aorta meet with success. And that's a very important thing to keep in mind, right?
Yeah. Yeah. So just because you can't see it doesn't mean it's not there.
So I'm going to leave with this kind of thing. Now, these are studies that looked at specifically how often we were able to see it. 52% of the time, these patients had inadequate views, or these bedside ultrasound emergency physicians had inadequate views. This study at 207 patients, 17% had inadequate views. 196 patients, 20.4 had inadequate views. And this one, 37.4% had inadequate views. So big caveat here. If you can't see the aorta, you can't make any kind of assumption, right?
And just because you can't see it doesn't mean you're a bad doctor. Like even in these like perfect settings, like where they're actually studying this, I mean, still like, between 17 and 48% of the time, they couldn't see the aorta well. They didn't have adequate view. So, when we can see it, great. When you can't, sometimes you got to get a CAT scan.
Yeah, and I think a CAT scan is perfectly fine. And no, it's kind of like with a pneumothorax, right? If you have subcutaneous air, you can only say the patient has subcutaneous air. You cannot say the patient has a pneumothorax. You can't say they don't have a pneumothorax, just that they have subcutaneous air. And there's always limitations, even though we love, obviously, we are the ultrasound podcast, right? But it's not the only test. It's a good test, but it's not the only test. And sometimes you have to use other stuff. And I think that's like probably, to me, this is the most important part of this. Yes, we can do it, but don't be dumb about it, right?
Yeah, and most of these people are going to get CTs anyway, right? I mean, at some point they're going to get a value, unless they're about to code. They're gonna try to figure out whether it's involving the renal arteries and all this other stuff. So it's not like you're not killing the patient's kidneys. You're not doing them a disservice. Yeah. So it's okay. You got to get a CT. Get a CT. Okay. So Jacob, this has been great, and I guess one thing I'd like to say, just to remind everyone, also use color Doppler, because we didn't really talk about it much, but aortic dissection really falls into the same realm here. So make sure you're not looking at a dissection flap, because they can have similar presentations with kind of the back pain and the pain radiating to the groin and stuff like that. So color Doppler is a good one. But this has been, I think, a great review for aortic ultrasound. Now, is there anywhere that somebody can go and maybe learn this with some hands-on experience at the same time? Anything you can think of?
Oh man, I'm like so glad
locations, maybe somewhere that's got some really good mountain biking and like a river they can float in.
I'm so excited. Yeah. So this year we are doing Bend Fest in Bend, Oregon, and I've actually never been to Bend, and I've wanted to go so badly, and I also want to do some ultrasound, so we combine those two, synergy. Into two things, which is basically the best. My favorite part of medicine is ultrasound. My favorite part of like being alive is like being outdoors and doing fun stuff, like with mountain biking, with hiking, with rafting.
I'm there with you, buddy. Yeah,
I know, and right there. So the website you got to go to is bendfest18.com. Check it out, register. Let us know if you have any questions about it.
Nice. Yeah, it has everything to do with synergy, nothing to do with the fact that I live in Bend.
right. Yeah, it has nothing to do with that. Nothing to do with that. Right. Like your backyard now.
Right. Yeah. None of that. All right, man. Thanks. This has been great. I appreciate it, Jacob.
Right on, man. Bye.
if you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.